going to ask Johnny and then Chaand to respond to the challenge Rebecca put about, having real transformational change across particularly acute providers and how, because that's central to both the efficiency and the kind of health service challenge and changes that I think we're about. What are your thoughts about that? What levers will you have as the new breed of commissioners? Do you want to go first, Johnny?
I guess the question is what new levers will we have that we don't already have? And I think for me it's very much about relationship. And it's the primary care clinicians sitting down with the secondary care clinicians and actually a whole lot of other people. I wouldn't wish to say that it's just unique to them. And starting to understand that we have a collective responsibility. A collective responsibility for securing the best services and hopefully the best outcomes against the measured needs of a population within the resources that are available. And I think we often find that we end up competing with each other over that. Whereas actually, if we are collaborative around that, I think for the voluntary sector as well, I guess I have a fear the voluntary sector will come in and we will be promoting their particular specialist area that may put a pressure on my budget that I'll find difficult to manage. But actually, if they come with that collective responsibility, it adds enormous value to working out how we could do that better. And I think Paul's right in terms of GPs will be much more comfortable. I was a little bit concerned actually in the survey that so few of them recognise how this might actually improve the quality of primary care. That's a little bit of a worry. Fortunately, 61% of them recognised that they had good leaders locally, so hopefully those good professional leaders will be able to change that. But I think fundamentally changing the way we all provide is really the revolution. That's what we're trying to achieve, and I think that's what unites us, and I think that's what changes the relationship, or all sorts of relationships, and I hope that's the added value that we'll bring.
Chaand, your thoughts about that? Actually change the services.
I think it's a misnomer and also a flawed concept to consider GPs as being commissioners and this Berlin Wall, and then hospitals as being providers. To the patients I see, they see my care as being a co-provider in a spectrum where they go to hospital last week, they see me another week, then they go back. So I think we need to get away from this strict boundary that doesn't actually make sense to patients and isn't actually accurate either. So in order to change that, I do think we need better incentives and a payment system that incentivizes specialists in hospital and GPs in the community to work better together. The payment system we have now and the way it's operated has actually created, in my view, an unnecessary adversarial system of commissioning. So I really think that would transform a lot of the problems we have, and it's something I know that you've also advocated yourself. And I think the other issue around what will achieve transformational change is actually around the 75% of GPs who don't think this is going to make a difference. Because this will only change if GPs believe and own and are signed up to this agenda. And then they haven't owned and signed up to this agenda because of years of becoming increasingly skeptical, because the political pronouncements haven't matched the reality they perceive on the ground. And that's exactly what happened with practice-based commissioning. So I think what we must do this time is make sure that the rhetoric that says they will give clinicians leadership actually does translate from day one so that you don't get disengagement.
It's just running through my mind there, Chaand, when you're talking. Well, first of all, fascinated to wonder what the discussions are that are going on at the BMA at the moment about what you talk about payment and incentives, but perhaps hold that one at the moment. I don't expect you to talk about that in Chatham House rules. But also a thought that I think it's easy for the likes of us to talk about transforming services and primary care changing as much as secondary care. But it seems behind that the big question is we've never sorted out how to create a narrative that the public in particular will trust about all of that. So it isn't just about closures. And I was wanting to pick up on that very important question about the voice of patients and communities. And I'm going to ask you, Paul, to comment first, and then Penny, if you can say something about that. You know, because I think for me it feels that's something that needs to be different this time if this is going to work.
I think there's two. We think about this in two very different ways. The second way we think about it, and the way in which we spend a lot of energy working out about it, is around patient engagement with a capital P and a capital E, around their citizenship role. What we were talking about and what the big society discussion was about earlier on is the much more critical thing, which is actually their engagement with their health. and their engagement with a health service which is engaging with their health, and how they are co-producing their health. If we could have some wonderful bits of engagement with a capital P and a capital E, but if we don't solve that, the NHS goes bankrupt. So it seems to me it is that level of co-production of health which is absolutely crucial for everybody to get involved in and allow patients, which I don't think the health service does at the moment, to add value to their own health. I think there is then within the reforms a whole range of relationships around public engagement, which calls for a much greater, in your word, honest narrative with the public, that we are working in a health service which actually people love the outcome of the changes in that health service and really do love it and love the changes in their lives that come about from those outcomes, but we've not been truthful with them about the nature of the changes in those institutions which are necessary to bring those outcomes.
Yeah, that's really helpful. Penny, your reflections on that?
Well, I think I largely agree, well, I completely agree with what Paul said, and so I'll just add to that. So I think starting with the second point, absolutely, and we have not been in the slightest bit honest. I think I still continue to find it puzzling why, when there was a big issue around cot deaths, they were headlines on every single front page of every newspaper, and yet the 120 unnecessary deaths of newborn infants in hospitals that took place outside of 9 to 5, Monday to Friday, got one tiny line on the BBC News website. And I think that sort of thing is quite fascinating. Equally, a very real story I heard last night from a small midwife-led unit somewhere in the south of the country, where just in the last 6 months alone there have been 3 maternal deaths and 2 infant deaths, which are recognised it should not have happened if they'd have taken place in a midwife-led unit alongside an obstetric unit. So we're not being open with the public at all. The only reason why stroke services have changed is because we were open with the public, and we very visibly put that into the public domain and so on. So I think that absolutely needs to grow and be more of it. And if you want an interesting example, look to Denmark, where they've very actively done that in the last 5 years and are very keen and happy to share how they've done that, which has been a big public campaign, and they've now got to the point that people ask to go to the centre of expertise, and they understand when they can have things done locally, and they completely recognise that there are different sorts of services for different needs. How does that work in the new world? I'm actually, where I slightly disagree with Paul and a bit of this urban myth that we've got a history of failed reconfigurations. Actually, we don't. We have some very successful reconfigurations, and the ones that I've seen be very successful have largely been the ones where GPs in particular have stood up on the stage and told the story. So Martin McShane, who's Deputy Chief Exec at Lincolnshire PCT, talks very eloquently, and it was in the HSJ a couple of weeks ago, about the Louth story, where the GPs have taken over Louth Hospital. They've turned it from a DGH into a 24/7 A&E run by the GPs, with emergency admissions run by the GPs, and the GPs led the whole of that. They had no uproar about it, wasn't referred for judicial review and so on. So I think these things all fit together, actually.
And it's interesting, again, you're telling a story about provision in many senses there as well, about what happened in Lincolnshire. I'm just going to ask you, Malcolm, for your just your thoughts on the kind of patient community sort of public voice and all this. And then in a moment, just to put you on watch, I'm going to turn back to all of you for any final reflections, comments, things that have got you exercised while you've been listening to the panels. Malcolm.
It's such a publicly unstable environment that people are prepared to do things which are comparatively unusual. And we might want to return to this in terms of what are the opportunities in the instability that is likely to be around in the next few years. And that point was made earlier in terms of its contribution to innovation. I think what's fascinating about the patient-public argument go on for ages, but what interests me most is when they get ahead of us as professionals or as institutions. They got ahead of us, frankly, although articulated through the media in terms of infection control. If you remember, we used to excuse ourselves about this. I think they will get ahead of us in terms of care for older people and require us to dismantle our existing, frankly, at best mediocre approach to that, now that we're warehousing large numbers of older people in hospitals for all sorts of contributory reasons. And also, we need to remember the function of the consequences of social networking. You know, when I make a tiny little adjustment to the nature of a service I support in a community hospital, or when I did by accident, the 20,000 people were active on a quickly formed social networking site. So there are all sorts of factors which I don't think we necessarily fully understand or yet now know how to control and bring in, but I think the opportunity is vast.